Hello and welcome to Conversations with Dr. Bachner. It's Howard Bachner, Editor-in-Chief of JAMA. And once again, I'm here with an extraordinary individual, Tony Fauci, head of NIAID. Welcome, Tony.
Thank you, Howard. Always good to be with you.
Couple difficult weeks, 60, 65, 70,000 cases a day, deaths now above 1,000. What's next month going to bring, Tony?
You know, that's going to really depend, Howard, on how we respond to what we see now is a real and potential pattern. It's become clear now that if you look back at the states in the southern region that have surged up, accounting for the 60, 70,000 new cases per day that you just mentioned, that prior to the surging, you could detect an early increase in the percent positive for any given state, even if it goes up by 1 or 1.5 percentage points and continues to go up. It generally doesn't spontaneously come down. It means it's a good predictor of a surge. What we're seeing in some of the yellow states and other states is that same insidious increase in percent positive that we've seen and pointed out, as Deborah Birx and I did recently at a governor call in states like Tennessee, Kentucky, Ohio, Minnesota, and others. So the critical issue is when you see that, you've got to take a look at where you are in the process of trying to reopen and take a good, serious look at what you want to do. You may need to pause. You may need to drop back a little bit. I don't think you necessarily have to revert to going all the way back to closing, but you've got to intensify what I consider 5 or 6 fundamental things that we know from experience help to blunt resurgences and can prevent resurgences from occurring. And that is consistent, correct wearing of masks, avoiding crowds, physical distance 6 feet or more, stay away from places like bars where people congregate. And in some places, you're even seeing authorities closing bars. Outdoor is always better than indoor if you want to do any kind of a function. And simple things like hand hygiene of washing your hands. That sounds really simple. It's not rocket science, but it really can be effective. So it's in our hands, Howard. I've said that so many times. You have the dynamics of the virus, if left to its own devices, is going to keep resurging. The only way we can stop it by what we do as a countermeasure against it, by trying to prevent that. And it can be done. It's not inevitable that you're going to see these surgences if, in fact, you handle it properly.
Tony, I like the list because it's doable, and there's more and more evidence about each one. We know that there's been outbreaks in Korea and other countries when they reopen the bars. We know outdoors is better than indoors, and we certainly know about masking. Tony, I had a question for you about masking. So I walk around Chicago, and I always mask when I go inside. Grocery stores are great. You're simply not allowed in a grocery store without masking. And I'm wondering if somehow we as individuals need to help. I'm shy about it, I'll be honest. But, you know, I go into Dunkin' Donuts. They have masking on the outside door, but people go in and they're not masks. And I don't know if I should say something to them. I haven't figured out a kind of personal connection. Or if you go into an ice cream store and it says masking on the outside, or a coffee shop, but then you walk in and people walk in unmasked. Do you think clinicians need to be more proactive and in a nice way say, you really need to mask?
Yeah, I mean, yes, I think we should be doing that, Howard. It's a touchy issue because you don't want to get into a confrontation with someone. You read about confrontations that really go bad. You don't want that to happen. I think what we really need to do is to just as a nation show a degree of consistency of everybody doing that. There's that argument, which is, interesting, about mandating, like from above, mandate, so that you do have enforcement at the level of authorities. The trouble with mandating is that you could have a counter reaction against it. In other words, people who push back on authority, if you mandate, they may push back even more. So what I think we should try and do, and I don't know, there may be some situations where it's appropriate and a good idea to mandate masks, but we just need to keep getting the message across is that we are all in this together. And it's important because one of the purposes of a mask is if you may be inadvertently not knowing that you are infected, to prevent others from getting infected, as well as a degree of protection yourself. We have to keep hammering home at that message. I'm very pleased to see that the president is wearing a mask more now. The vice president, I know I'm with him a fair amount. He wears a mask when he goes out and is in situations where masks are needed. We need more of that consistency.
I want to integrate some of the talks, rather some of the questions with some of the bigger questions I had. So one of them already came in, goggles and shields, face shields and goggles. How critical, Tony, from your sense of seeing the data and the history that you've spent in this field?
Well, any mucosal surface is susceptible, and that's one of the things that we often talk about when we say people should wash their hands, because they often touch their face and rub their eyes multiple times a day. So if you can get access to and easily get a goggle or face shield, it might be a good idea to do that. The question came up, it just started talking about that when I was giving a fireside chat with the American Federation of Teachers. And they were saying that several of them feel that in the classroom it's better that they would be wearing a face shield. And they asked me what I thought about it. And I said, if you can get one, it's not a bad idea. Sometimes, we have enough trouble people wearing masks. I would like to see universal wearing of masks. And for those who want the extra kick to it, go ahead and either get a face shield or goggles.
Tony, I had Mike Osterholm on about 6 weeks ago, and he half jokingly said, well, can you have me on 2 weeks later so I can correct all the mistakes or the misleading statements I made? Children have been a huge source of uncertainty. I think early on we thought they didn't get infected. They didn't particularly spread disease. I'm always uncomfortable when people just talk about children because children are 0 to 19, 20, or 21. And there's pre- and post-pubertal children. Most of the listeners know I'm a pediatrician. And from biological and physiologic perspectives, children who are 16, 17, and 18 often behave much more like adults. And that's different than 3, 4, and 5-year-olds. The more recent data are suggesting that perhaps older children, post-pubertal children, may be more like 20-year-olds. They may not get as serious disease, but they can spread disease. Do you have a sense of how this has changed just in the last couple of weeks?
Oh, yeah, Howard, it's a good point. And that's the reason why we really need to be humble and we really need to talk about things that we need to learn and yet at least articulate well the things that we do know. So there are multiple different studies. I think you summarized them quite correctly, but let me just quickly go through them. There's the Korean study which showed that children from 10 to 19 spread the infection as easily to adults as adults spread it to adults, whereas children who are younger than that do not seem to spread it as regularly. One of the things we need to make sure we don't confuse is the fact that when children get infected, statistically, if you look at the charts, clearly they have much less of a chance of getting sick and of getting a serious outcome. When you look at the hospitalization rate per 100,000 in the different age groups, there's no question that children are less likely to get seriously ill. Then there was a situation that says, well, maybe then children don't get infected as much. We don't know that yet. We need to do better studies on that. And the NIH has initiated a study called HERO study for human epidemiology and infection for COVID virus. 6,000 people, 2,000 families. The interesting thing that has also recently come out is that very young children, when you look at the viral load in their nasopharynx, it's anywhere from 10 to, in some cases, 100 times more than older children. So you can make a reasonable assumption that if very young children have a high viral load in their nasopharynx, that they're capable of transmitting it. So even though we're learning a week by week with new studies about infection in children, we need to assume that A, we know they don't get seriously ill, but they clearly can get infected. And the question is, how well do they transmit that infection to others? The Korean study indicated that at least children 10 to 19 can do it pretty efficiently. But we keep an open mind, and we'll learn more and more as the weeks and months go by.
Tony, my Lord, so many questions have already come in. Another controversy over the last 2 or 3 weeks has been aerosolization versus droplet. We published a viewpoint about generally the belief being droplet spread. Obviously, there was the letter written to the WHO about aerosolization, although if you read in the end some of the comments, I'm not sure it changes the approach outside of a healthcare facility. But I know this has made people nervous. Can you just comment on the droplet aerolization controversy?
You know, we're learning a lot about that now. I think that there certainly is a degree of aerosolization, but one of the things that I'm just going to take a step back and make sure that we learn the facts before we start talking about it. I'm getting correspondences from particle physicists and people who make a living out of studying and understanding aerosol. Much better than I know about it. And what they're saying is that we have a little bit of a distortion in our understanding of what can actually stay in the air longer. You read the classic literature, and I got to go back and study that even more now and learn from the people who do this every day. We usually say, well, regular particles that are from, coughing and sneezing, they're greater than 5 micrometers. They tend to fall to the ground within 3 to 6 feet. Then we find out from the aerosol particle scholars that say, there are larger particles than that stay floating around a lot longer. So you shouldn't assume they all go to the ground, which adds weight to the role of aerosolization, namely something that'll stay in the air. And maybe the size of it is something we need to re-examine. So I'm trying to get some of those people to talk a little bit more to us about it. The one thing that it does tell you, it's important, is that you really better wear a mask. I just think all this information, sometimes as conflicting as it might be, we need to straighten it out. But it also tells us something about indoors versus outdoors. It's become much clearer now that the circulation and recirculation of air, if you have any degree of aerosolization and you are in an indoor space where the air is being circulated, that it makes sense to assume that that is a much greater risk than if you are outside. So we need to pay a little bit more attention now to the recirculation of air indoors, which tells you that mask wearing indoors when you're in a situation like that is something that is as important as wearing masks when you're outside dealing with individuals who you don't know where they came from or who they are. It's something we're learning more and more about. We got to make sure that we're humble enough to accumulate new knowledge and use it as we get it.
Tony, I'm not going to spend that much time on specific vaccines. You've been very clear over the last couple of weeks. You're guardedly optimistic we'll see something in late this year, early next year. There's many candidate vaccines. You're involved with assessing many of them. But I have 2 or 3 very specific questions about vaccines. I had the pleasure of talking with Steve Hahn, who's commissioner of the FDA. They're going to be under enormous pressure in the fall. They'll begin to see data from the phase 3 trials. They've issued guidance about approval. What data do you think the American people need to see? That we need? Do we have to approach this approval process differently? Does there have to be greater transparency? Does there have to be an outside group that helps the FDA? What data do you think the public needs to see to be reassured about the approval of a vaccine?
Well, everything needs to be transparent. I mean, that clearly, if you're going to gain the confidence of the American people to either engage in a vaccine trial or act upon the results of a vaccine trial. We need to show in a randomized placebo-controlled trial safety and efficacy. The reason it's very important is that if a vaccine gets the imprimatur of the FDA, it's going to be given to millions and millions of people. So you want to be sure that you're giving people who are otherwise well something that has been proven to be safe and has proven to be effective. Because even a safe but ineffective vaccine could lead to a false sense of security. So you need both safety and efficacy. We have data and safety monitoring boards that you're very well familiar with, Howard, that intermittently will be looking at the data to determine, A, is it futile? Namely, no matter what, this is not going to work. B, is it detrimental? Is there this unforeseen negative, deleterious effect? Or C, is it in fact looking like it's going to be effective and we can now say we have an effective vaccine? That's an independent group that's independent of the clinical trialists, that independent of the company, and that ultimately those data will be made available in a transparent way, published in journals like JAMA and other journals.
Tony, do you think we could ask the manufacturers, and I know it's difficult for them, to restrain from issuing press releases on early data? I find it disturbing. You know, you get a paragraph, this vaccine was successful, but there's no data that underpins the press release. We know it's on rapid review at the FDA. Is there a way of, do you think it's even reasonable to ask that they restrain themselves from press releases about early examination of data?
Yeah, I actually think that that's a very good idea. Sometimes they have to make things known when it has to do with the regulations.
Security and Exchange Commission or something.
Commission, which something as a researcher I've never gotten involved with as an academic and as a government employee, but the companies sometimes tell us they have to do that. They have to make something public, even though it isn't in the arena of the normal academic circles that you and I work in.
Tony, when I spoke to Steve, the other thing that he mentioned that I mentioned in the podcast I hadn't even really thought about is this activation of people who've had disease when they are vaccinated. Can you talk a little bit about that? I mean, the CDC estimates that upwards of 10% of the U.S. population has now been infected. That's 35 million. Let's say it goes to 20% by the fall. So then there's 70 million people who literally could have been infected. We're going to roll out a vaccine. I don't quite understand this concern about activation of someone who's previously been infected.
I don't know what that means, to be honest with you, Howard. I don't know what the word activation means. What do they think that they're activating?
It was around pulmonary or respiratory disease.
I see. What they're thinking is that if you have an immune response and you trigger another immune response, is there concern,
correct,
Howard, that you might trigger an aberrant immunological response to the vaccine, similar to the sometimes unusual, rare, but it occurs, of an aberrant inflammatory response like you see in children with the multi-system inflammatory response. I believe that's what you're talking about.
Correct. Sorry.
You're talking about, yes.
A concern, or is it just one of the safety parameters that people are going to have to follow?
Well, it's going to be one of the safety parameters. And Howard, you make a very good point by bringing that up, even though it would be an unusual occurrence. It's the reason why when you're dealing with a new intervention, with a brand new virus, you've got to be careful about safety. I know there is this urge, understandably, to as soon as possible get that vaccine out to everybody. But you've really got to be careful because there are a lot of unknowns about this. And, the history of vaccinology, has some pretty cogent examples of things that went awry. That's the reason why you have a randomized placebo-controlled trial to show not only efficacy, but also safety. Very important.
Tony, is there anything new on treatments? Remdesivir was successful. I think people are uncertain about how successful. I think steroids have proven to be far more effective. There are a number of trials that are about to be reported in the coming weeks. I think we'll begin to see meta-analyses. Everything else around treatment has seemed to have quieted down. I think you see more data before other people do. Anything else that you expect to see come out or be reported? I mean, cyclosporin crosses my desk. Many different issues cross my desk, or therapies, but I haven't seen much more data about them.
Well, the two that you mentioned, Howard, as you well know, are dexamethasone, which was shown very clearly in a randomized placebo-controlled trial for advanced disease. People on ventilators, people with oxygen, but not good for people in early disease. It is significantly diminishes the death rate. Remdesivir for people in hospital requiring oxygen. What we really do need, and these are things that are being pursued very actively now, are things for early disease, namely people who are infected, but you want to prevent them from going on to advanced disease requiring hospitalization. And there are a number of trials right now as we speak, very, very timely, Howard, because there'll be two trials this week that are going to be going in for monoclonal antibody, one in an outpatient basis for people with early disease, one on an inpatient hospitalized people with more advanced but not very advanced disease. There is a lot of activity to try and determine if convalescent plasma does or does not work. It's still a bit of an open question. It looks some favorable, suggestive results. We need to nail that down with the proper clinical trial. Then there are other small molecules. For example, direct antiviral molecules that are being tested, and there are immune modulators. The thing that we really need very much so is those early intervention, in addition to prophylaxis. Now, monoclonal antibodies can be used both for prophylaxis as well as for treatment. And in fact, there's a nursing home study that will be launched soon, a phase 3 study in which you're looking at trying to prevent it in nursing homes in which there's a case that might endanger the other inhabitants of the nursing home. A lot of activity going on. In the next few months, Howard, I think we're going to get some important data.
Now, Tony, that will all be critical for the fall. I don't think anyone anticipates a vaccine late into this year, early next year. Maybe I'll be wrong. So then the fall becomes critical. We go inside. We may have to close restaurants and bars in ways that we hadn't thought about. The whole contentious issue about schools opening for in-person, not in-person. But the fall brings, in the northern part of the country, winter and cold weather. Do you have any sense of what the fall will look like? And do these treatments become even more critical?
Well, certainly the treatments will become critical. I do not know, Howard, nor can anyone know what the fall is going to bring. You know, people were talking in the spring about the big surge we had, that everyone was hoping it would go down to baseline. And they were talking about the second wave in the fall. You look at our numbers now, you know, as I've said often, and it's the truth, we're right in the middle of the first wave here. We're having surging of cases, you know, the last one's anywhere between 50 and 60,000 per day with 1,000 deaths per day. We've got to get those numbers down. If we don't get them down, then we're going to have a really bad situation in the fall, because as you get indoors and you get the complication of influenza, that's something that we're going to have to deal with. So right now, what we're really focusing on is doing the things that I mentioned, the 5 easy things that one can do to try and turn that curve around so that as we enter the fall, we're really at a low baseline. Because remember, when we went up, which was driven mostly by the northeastern section of the country, dominated by the New York metropolitan area, which accounted for many of those cases that peaked. When we came down, Howard, we came down to a baseline of about 20,000 cases a day, which is not a favorable baseline. And then as we try to open the country for economic reasons that are quite valid, what happened is that we saw surgences that brought it right up. So we got to get our arms around that and get that contained as we enter into the fall.
Yeah, I think Bob Redfield said the same thing. You know, those five approaches that you talked about to really try to drive the national caseload to under 10,000 by the end of August, early September. Right. Or otherwise, the complications for October, November, and December, although uncertain, will be potentially catastrophic for the healthcare system. Tony, when you look back at 7 months, 8 months now, when you look back, what have been the 3 great successes or 4 great successes, do you think?
Well, I think one of them was the rapidity with which we closed down travel into the country from areas that were really, really hot. I mean, we all know, Howard, you and I were discussing this way before COVID-19 came, is that when you get a pandemic, you're never going to be able to get any country that's going to completely be free of this. It's almost the definition, right in the meaning of the Latin derivation of the word pandemic. But we really saved a lot of infection by closing down travel from China and then closing down travel from the European Union. That was one. The other one was when we shut down, when we had the 15 days of shutdown, and then when we extended it to 30 days, that was also another, I believe, success in curtailing the number of infections. I think the rapidity with which we got our vaccine trials going, record time without compromising safety and without compromising scientific integrity, and then the therapies now, the dexamethasone that the UK should be given a lot of credit for, also the remdesivir, and now getting a bunch of candidates of monoclonal antibodies, hyperimmune globulin, potentially convalescent plasma. Those are important things. Those are things that I think are positives, but we're dealing with a challenge that's a formidable challenge here as to what we're going through right now.
2 more, last question, then a comment. Tony, the 3 things, you know, you go home Sunday, I don't know, maybe you're drinking a glass of wine or having a beer, and you go, I wish we had done these 3 things better. And you and I try, we don't point fingers. It's not what this conversation is about. But maybe the 3 things that you think we could have done better as a nation.
You know, Howard, I hesitate to do that because that then gets distorted as something you've done wrong, and it becomes, you know, a soundbite, you know, a topic of discussion that distracts us from looking ahead. I can tell you in general, we're not perfect. We did not do everything right, but nobody has done everything right when you're dealing with this brand new. So I would rather not point something out. You know, you're right. We've been through now 6.5, 7 months of this. And I know when you say that, somebody's going to distort it. Let's just be humble enough to know that we all could have done better.
Yeah, I've said I think there's ways in which journals could have done better. You know, I do think about it. You're in a very different position, and I really appreciate that answer. I think it's the wise answer, Tony, and you've shown me repeatedly that you're quite wise. But Tony, I would be remiss. The baseball throw. My Lord, Tony, I know you've been asked. But firstly, hold on. You grew up in Brooklyn. You're a New York Yankee fan, and now you're a Nats fan, and you throw out that first pitch. What happened?
Well, it was misjudgment on my part. I was practicing from what I thought was 60 feet.
Yeah,
I was throwing the ball really, really well. I actually threw my arm out. I practiced so much. And then I don't know how I miscalculated. When I went out to the mound, it was so exciting and such an incredible moment. When I got to the rubber on the mound and I looked at Sean Doolittle, he looked like he was about 500 feet away.
They're really far apart, huh?
So I said to myself, instead of throwing it with my natural, just throw it, I decided to have to throw a bullet. The only thing, Howard, the bullet went towards first base.
Yeah, no, everyone, you know, the joke, you've probably heard the jokes. Oh, he wanted the ball to socially distance, you know, things like that. Did you get the ball? Do you get to keep the ball, Tony?
Yeah, I did. Yeah, that were really very nice about it. I hope baseball is going to be able to successfully complete the season. They certainly got challenged when you had clusters of players that have gotten infected. I hope they can work that out safely and that the players stay safe and well.
Well, you certainly want everyone to be healthy. I mean, I've commented, I think it's the Marlins that had the most disease. But if all of their players get infected and then are healthy, they may be the only team that makes it to the World Series intact. I mean, that's the irony of as long as they all stay healthy and their families stay healthy. Yeah. Tony, you're a national treasure. I say that to people repeatedly. It's been a long 7 months. I just hope you can stay healthy and continue the remarkable contribution that you make on a daily basis to the health of the population in the United States and around the world. Thanks, Tony.
Thanks a lot, Howard. Thank you very much for having me. I appreciate, always look forward to being on with you.
All right. Be well. Take care.
You too. Thanks.
Bye-bye.